So let's talk about the treatment modalities we have available, what we're going to do in general, and what specifically we're going to do in case of acute mesenteric ischemia and in case of the chronic mesenteric ischemia. So in general, if you're suspecting a case of acute mesenteric ischemia and the patient is in shock or a patient has already developed generalized peritonitis, then fluid resuscitation, oxygen, intubation, monitoring your patient, NG tube, broad spectrum antibiotics, stop vasopressors, and invasive hemodynamic monitors. And if there's a arrhythmia, tachyarrhythmias are present, then you have to treat your patient accordingly with the tachyarrhythmias. Building up your patient is very, very much important. If you are trying to resuscitate your patient with the fluids, okay, and he's not responding, then maybe possible you have to put your patient on the inotropic support, okay. Oxygen inhalation is very, very much important because your gut is already hyperperfused, okay? So if the atmospheric oxygen available is low, then there's a more chance of more hyperperfusion, okay? So you have to give your patient oxygen support. You have to cover the broad spectrum antibiotics. So the patient has already developed the sepsis and the signs of the diffuse peritonitis, then you have to put your patient on broad spectrum antibiotics. So fluid resuscitation, oxygen inhalation, maybe intubation, monitoring the patient, broad spectrum antibiotics, supporting resuscitating your patient with the inotropic support, and treating the arrhythmias. So in generally, first you have to do this. If the patient is stable, go for angiogram, go for CT angiography. And then on the basis of angiography, considered if you need the vasodilators or you need the anticoagulation, okay? So if you're suspecting, you have to start the heparin as well, okay? So remember, you need to start the heparin infusion as well if you're suspecting a case of acute mesenteric ischemia. And if there is a possibility, if the patient is stable and you do a CT angiogram, and if there's a possibility that radiological intervention can be possible, so you can go for radiological intervention. And if the patient is unstable or there are signs of peritonitis, then you have to take your patient to the OR because it's a surgical emergency, and you have to do the exploratory laparotomy. You have to keep resuscitating your patient with the fluids and with the blood products. And also, if the patient is bleeding internally a lot and there's a sign, the patient has full-blown peritonitis, then try to resuscitate your patient with the fluids as well. Okay, so laparotomy, continue the resuscitation and decide whether the gut is viable or not. If the gut is not viable, it's not healthy, and it's gangrenous, then you have to resect that portion. And sometimes if the patient is in septic shock, or obviously the patient has already diffuse peritonitis, and there is a lot of the fluid and pus in the peritoneal cavity, then you just have to wash the cavity, just resect the necrotic patch of the bowel or necrotic segment, and just do the it's not advisable to do the if you're not very much confident about the healthy gut. And obviously you can't resect that much large portion of the gut because obviously the mortality would be very much high. So either in the laparotomy on table, you decide either you can do the revascularization or you have to do the bowel resection. So either you can, what you can do is like you can just get rid of the necrotic portion if the gut is not viable, okay? So if the gut is still viable, and you can see if you resuscitate or if you revascularize the patient, either embolectomy or by the bypass. So on table you have to decide that, and you have to plan accordingly. So in laparotomy, if you're not confident, do the damage control study, just a damage control surgery, and just pack your patient and go for a second look laparotomy, like and the time ranges between 24 to 48 hours resuscitating your patient. So that's the, if you're suspecting a case of acute mesenteric ischemia, that's the algorithm you have to follow. If stable, do angiogram and consider the interventions if you have if you have possibilities of intervention around it in your premises. If the patient is unstable, not hemodynamically stable, and in diffuse peritonitis, shift the patient to OR, do the exploratory laparotomy, and on table decide, depending upon the segment or viability of the gut, just decide about revascularization or decide about the bowel resection. Okay, so in interventional radiology, we have some options. One is a catheter-directed infusion of the vasodilators, or you go for catheter-directed thrombolysis. So if you're treating your patient, you suspect that it's acute mesenteric ischemia, but the patient is stable. There is just a history of severe abdominal pain, but there are no signs of peritonitis. There's no guarding, no tenderness, no rigidity, and the patient is vitally and hemodynamically stable. Okay, again repeating, if the patient is vitally and hemodynamically stable, so in those patients you can put the patient on medical treatment, or you go for the catheter-directed infusions of the vasodilators like piperavine, and you can do the catheter-directed thrombolysis, which is the angioplasty. You go from the femoral artery and then all the way you go to the SMA and you do the stenting and angioplasting. That's with the intervention. But in a patient who is stable, in a patient who is hemodynamically and widely stable, for the patient who has diffuse peritonitis and is not hemodynamically stable and is already in shock, the option is open surgical procedure. So remember, you have to differentiate between if you go for interventional radiology or you go for like invasive surgery. So in minimally invasive surgeries, you can perform only minimally invasive surgeries in stable patients. You can't perform interventionals in unstable patients. So stabilize the patient, see CT angio, and see if there's a possibility of minimally invasive surgery.